Lesson 3. The role of pharmacotherapy in the treatment of schizophrenia. Pharmacotherapy is the foundation of treating schizophrenia. Without it, the person's brain is unable to remain stable, and psychotic symptoms, delusions, hallucinations, thought disorder, anxiety and agitation return. Antipsychotic medication is not an add-on or an optional extra, it is the basic tool that maintains chemical balance in the brain. It is precisely thanks to it that therapy, a return to everyday life, social relationships, and even relatively normal functioning become possible. Without regular pharmacological treatment, the course of schizophrenia usually becomes more severe, more recurrent, and increasingly difficult to stabilize. For the caregiver, understanding this process is absolutely crucial. Contrary to appearances, the caregiver's role is not limited to simply reminding about the pill. The caregiver is the person who first sees the effects of the medication, both beneficial and adverse. They see when the meds help calm the mind, and when they begin to cause excessive sleepiness, muscle stiffness, agitation, or metabolic problems. They see when the person starts to function in a stable way, and when they begin to secretly hide tablets, stop treatment, or react to it in an unusual way. In the relationship with the psychiatrist, the caregiver acts as an observer, providing information without which the doctor cannot optimize the treatment. In this lesson, the caregiver receives knowledge that medical textbooks usually address to professionals. In practice, however, it is precisely those closest to the person, parents, partners, siblings, who must learn to recognize the effects of neuroleptics, notice the first side effects, and respond before a small signal grows into a serious crisis. You will therefore get information about the main groups of medications, how they work, and what kinds of bodily reactions to expect. You will learn to recognize extrapyramidal symptoms, metabolic disturbances, dosage problems, and the phenomenon of covert medication discontinuation. You will also find out which exercises, daily habits, and lifestyle elements can support pharmacotherapy, and which ones weaken it. The aim of this lesson is not to teach you how to prescribe or manage medication. That is the doctor's task. Its aim is to equip you with the knowledge that allows you to become the psychiatrist's best ally in the person's treatment. Your calm, vigilance, and understanding of how the medication works have a real impact on whether the person remains stable or their condition begins to deteriorate. In the pharmacotherapy of schizophrenia, the caregiver is an invaluable link, and this lesson will show you how to fulfill that role consciously and safely. Why antipsychotic medication is used and how it works. Understanding the purpose of pharmacotherapy is one of the most important elements of a caregiver's work with a person with schizophrenia. This is the point at which it is worth realizing that antipsychotic medication is not a tranquilizer or a short-term aid, it is the basic tool for stabilizing a brain that, without it, loses its ability to regulate its own activity. Schizophrenia is a biological illness. In its course, dopamine and other neurotransmitters are processed abnormally, and neuronal networks begin to function in a chaotic, overactivated, or poorly synchronized way. It is at this level that delusions, hallucinations, thought disorder, and anxiety arise. Antipsychotics act primarily by blocking D2 dopamine receptors in specific areas of the brain. You could say they turn down the volume in those neural circuits that are excessively active during a psychotic state. They do not switch off thinking or consciousness, as people sometimes fear. They do not take away personality. They stabilize neurotransmission, that is, they restore the brain's ability to function in an orderly way. Thanks to this, people with schizophrenia can once again begin to understand their experiences, distinguish reality from imagination, and return to their lives step by step. It is important to emphasize that the effect of antipsychotic medication is slow and subtle. It does not work like an antibiotic that reduces fever within a few hours. In schizophrenia, the body needs time to return to stable functioning. Typically, the first positive changes appear after several days or weeks. Sleep improves, anxiety gradually decreases, thoughts become more organized. Full stabilization may take several weeks and, in some cases, several months. For the caregiver, it is important to understand this pace. Treating schizophrenia requires patience, consistency, and regularity. Antipsychotics do not cure schizophrenia in the sense of removing its causes. They stabilize the illness and keep symptoms under control. This allows the person to live, function, and benefit from psychological therapy, which supports them emotionally and socially. Pharmacotherapy is therefore the foundation. Without chemical stabilization of the brain, the person cannot participate in therapy, build relationships, work, or learn to manage their experiences. The caregiver should also know that medication effects are highly individual. The same dose may help one person and cause excessive sedation in another. For some people, medication initially causes activation, for others, the opposite, deep sleepiness. This is why the caregiver's role as a careful observer who can describe the person's behavioral changes to the doctor is so important. The point is not to judge, but to give factual information: how the person sleeps, how they move, how they react to stimuli, how much they eat, whether they are agitated or slowed down. Pharmacotherapy is therefore not just a technical element of treatment, it is a delicate process of tailoring doses and medications to the needs of a particular person. In this process, thanks to their everyday presence, the caregiver becomes one of the psychiatrist's most important sources of information and thus a co-creator of effective treatment. Types of medication: what the caregiver should know. In the world of pharmacotherapy for schizophrenia, there are many medications that target similar symptoms, yet in practice differ in how they work, the intensity of side effects, and the speed with which they stabilize the person. The caregiver's goal is not to become a pharmacist or memorize all the names. The aim is to understand why one person may respond better to certain medications than to others, why the doctor sometimes changes the treatment, and what the caregiver should pay attention to in order to support this process wisely and consciously. Antipsychotic medications are currently divided into two main groups, so-called typical, first-generation, and atypical, second-generation, antipsychotics. This division reflects differences in how they act on the nervous system. Some block dopamine receptors more strongly, while others also affect serotonin, which changes their action profile and side effect profile. Typical antipsychotics, such as haloperidol, pyrazine, or chlorpromazine, have been used for many decades. They are effective in reducing delusions and hallucinations, but they are often associated with a higher risk of extrapyramidal symptoms, muscle stiffness, tremor, movement difficulties, and involuntary movements. In many countries, they are still used in acute states because they can quickly calm extreme agitation or anxiety, but they are usually not the first choice for long-term therapy. It is worth knowing that some people respond very well to them, especially if the illness has an acute, intense character or when other medications have been ineffective. Atypical antipsychotics, such as olanzapine, risperidone, quetiapine, aripiprazole or amisulpride, are now the backbone of schizophrenia treatment. They were developed to be more effective against positive symptoms, delusions, hallucinations, while having a milder impact on the motor system and emotions. Many patients tolerate them better and function more naturally on them. However, these medications can cause other problems: weight gain, increased appetite, sleepiness, disturbances in glucose metabolism. Therefore, the caregiver should pay attention not only to the person's mental state, but also to everyday physical parameters: weight, energy, daily rhythm, level of activity. A separate category is long-acting injectable medications, often called depot or LAIs, long-acting injectables. They are administered once every few weeks and the drug is released slowly into the body. This solution eliminates problems with forgetting tablets, hiding them or stopping medication behind the family's back. Many people who struggle to maintain regular treatment live much more stably thanks to depot injections. For the caregiver, this is a huge relief. There is no need to monitor a daily medication schedule, and any changes in the person's behavior are easier to link to other factors than to irregular treatment. It is also worth mentioning adjunctive medications that the psychiatrist may add in certain situations, for example, anti-anxiety drugs, mood stabilizers, or sleep medications. They have their own risks and limitations, so they must never be used without close medical supervision. When chosen appropriately, however, they can help the person calm severe tension, improve sleep, or ease mood swings, which often accompany schizophrenia. The caregiver does not need to know all of pharmacology, but it is helpful to understand that every medication has its own action profile, its own potential side effects, and its own role in treatment. This makes it easier to notice when the medication is working well, when it is beginning to work too strongly, and when it is causing problems that need to be reported to the doctor. Pharmacotherapy in schizophrenia is a dynamic process. It requires adaptation, observation, and response. A caregiver who knows what to expect becomes an important and informed partner in this process. Extrapyramidal side effects. Extrapyramidal side effects, EPS, are among the most important adverse effects of antipsychotic medications. They do not appear in every person, but if they do, they are visible, hard to miss, and can significantly impair functioning. For the caregiver, the ability to recognize them is crucial, because EPS often indicate that the dose is too high, the body is overreacting, or that a change of medication is needed. Extrapyramidal symptoms result from excessive blockade of dopamine receptors in the brain's motor system. They are not the person's fault, not the result of poor physical fitness or lack of motivation. They are the body's biological reaction to the drug. A psychiatrist can correct this, but in order to do so, they need to know exactly what appears and when, and here the caregiver's role is invaluable. Drug-induced Parkinsonism. This is one of the most common extrapyramidal effects. The person starts to move more slowly, as if each step weighed more. Their gait becomes small-stepped and cautious. Arm movements are smaller and more hesitant, and they are reluctant to perform quick tasks. The face may become less expressive, medically described as a masked face. The person may complain that they feel heavy, that it is hard to stand up, hard to walk, hard to lift their arms. This is often accompanied by tremor of the hands or fingers. For the caregiver, this is a sign that the body is reacting too strongly to the medication. Drug-induced Parkinsonism is not irreversible. It usually resolves after dose reduction or a change of medication. That is why it needs to be reported to the psychiatrist promptly. Akathisia. This is a symptom that is often mistaken for psychotic agitation, but its mechanism and meaning are completely different. A person with akathisia looks as if they cannot keep still. They pace around the room, sit down and immediately get up again, rock back and forth, shift from one leg to the other, move their feet or hands. They may say that they have to move, that they cannot stand being still. Akathisia is often extremely distressing emotionally. It causes suffering, tension, and a sense of inner pressure that the person cannot explain. It often increases anxiety and may raise the risk of suicidal thoughts. The caregiver must take akathisia seriously and report it to the doctor urgently. It is a symptom that psychiatrists usually correct because it is impossible to function normally with it. Dystonia. Dystonia is the most dramatic-looking extrapyramidal symptom. It can appear suddenly. The person's neck twists involuntarily, the head tilts, the eyes may roll upwards, the jaw clenches and the limbs become rigid. Although dystonia looks frightening, it does not mean that the nervous system has been permanently damaged. It is the result of the medication acting too strongly on dopamine receptors. It requires urgent contact with a doctor or going to an emergency department, where a medication, for example, piperidine, is given to interrupt the episode immediately. Dystonic episodes do not pass on their own. Important, dystonia often appears shortly after starting a new antipsychotic or increasing the dose. Tardive dyskinesia. This is a symptom that may appear after long-term use of some neuroleptics, especially typical antipsychotics. The person may make involuntary movements with their mouth, smack their lips, move their tongue, suck their cheeks or chew without food. Tardive dyskinesia is highly characteristic. If you notice it, record it and report it to the doctor straight away. Early intervention gives the best chance of stopping it. Why the caregiver must react quickly. Extrapyramidal side effects are not minor inconveniences. They are a sign that the brain is reacting too strongly to the medication and that the treatment needs adjusting. Ignoring them can lead to a marked decline in the person's quality of life. The person stopping medication, the most dangerous consequence, worsening of movement disorders, increasing anxiety, depression or aggression, in some cases, the need for urgent hospitalization. For the psychiatrist, information about EPS is often more important than the description of psychotic symptoms, because it shows how the body is coping with the dose and whether the treatment is safe. What to do when extrapyramidal symptoms appear? The most important thing is to stay calm and follow a simple scheme. 1. Record the symptoms. Write down when they appeared, how long they last, whether they are constant or occur in episodes. 2. Do not stop the medication on your own. This is the most common mistake families make. Abrupt discontinuation can trigger an acute psychotic episode within hours. 3. Contact the psychiatrist. In many cases, a change in dose or adding a corrective medication for EPS is enough. 4. If the symptoms are severe, dystonia, strong akathisia, disturbances of consciousness, go to the emergency department. Without fear and without shame, this is a natural part of treatment. Metabolic changes. Metabolic changes are among the most common and at the same time most underestimated side effects of antipsychotic medication. For the caregiver, knowing about them is extremely important because they appear gradually and do not immediately cause concern in the person taking the medication, who usually does not notice them. Ignoring these changes can lead to serious health problems, obesity, insulin resistance, type 2 diabetes, hypertension, or lipid disorders. In the pharmacological treatment of schizophrenia, it is usually the family who first notice that the person's body is starting to change. Not all medications carry the same risks. The greatest tendency to cause weight gain is seen with olanzapine, clozapine, and quetiapine, with somewhat lower risk for risperidone and amisulpride. The most metabolically neutral are aripiprazole, haloperidol, and ziprasidone. It is important to remember, however, that every body reacts differently, and metabolic changes can occur even with preparations considered safer. Weight gain usually begins after just a few weeks of treatment. Initially, the person may develop an increased appetite, especially for high-energy foods, sweets, bread, fried dishes. This increase in appetite does not result from cravings or weak will, it is the effect of the medication on hunger and satiety receptors in the brain. The caregiver should respond to this with empathy, not reproach. It is not the person who chooses this appetite, it is the body responding to chemical substances. At the same time, there may be changes in how the person feels their energy. Some people feel constantly sleepy, which reduces spontaneous physical activity. The combination of increased appetite and reduced movement leads to rapid weight gain. Some people gain 15 to 20 kilograms in just a few months if the process is not observed and managed. Metabolic changes are not a cosmetic issue. They are a health issue. Excess weight and disturbed glucose regulation increase the risk of heart disease, diabetes, and complications, and can also worsen mood and self-esteem. The caregiver should therefore treat this part of therapy as seriously as psychotic symptoms. Modern clinical guidelines recommend regular monitoring of weight, glucose levels, and lipid profile in every person taking neuroleptics, and it is usually the caregiver who reminds about these tests and makes sure they are done. However, metabolic changes are not unavoidable. Proper diet and small habits can significantly slow down or stop this process. In the first months of treatment, it is worth introducing fixed meal times, limiting sweets and highly processed foods, ensuring regular water intake and including at least a daily 30-minute walk. Sometimes even a minimal amount of exercise is enough to stimulate the metabolism so that rapid weight gain is prevented. The caregiver should not use harsh control or pressure. The person cannot become remote controlled like a child. This only leads to conflict and a loss of trust. Much better results come from suggesting joint activities, cooking together, walking together, planning meals together. With antipsychotic medication, balance is crucial. The body must be safe, but the person must also feel respected and in control. If weight gain becomes clearly visible and rapid, it is worth talking to the psychiatrist about possibly switching to a more metabolically neutral medication. In some cases, a dietitian's consultation is necessary, especially if the person already has hypertension, insulin resistance, diabetes, or cardiovascular disease. Involving a dietitian often works wonders. With individual guidance, the person does not feel scolded or restricted, and the caregiver stops being the food police. Metabolic changes are a constant feature of many neuroleptic regimens, but they do not have to be a tragedy or a reason to give up treatment. With proper observation, gentle support, and cooperation with the doctor, most of them can be managed. The most important thing is that the caregiver understands that this is not the person's fault and can respond with understanding, care, and calm. How to recognize that a medication is working poorly or the dose is too high. For the caregiver, one of the most difficult but also most important tasks is being able to see when pharmacotherapy starts to work incorrectly. Antipsychotic medications can be extremely helpful, but their effectiveness depends on how precisely the dose is adjusted. If it is too high, it will mute the person, take away energy, disturb emotions, and their natural rhythm of functioning. If it is too low, it will allow psychotic symptoms to return. A poorly chosen medication can paradoxically aggravate some problems instead of calming them. The psychiatrist sees the person a few times a year, sometimes once a month. The caregiver sees them every day. Everyday observation is therefore the most reliable source of information about how the medication is affecting the body and mind. Excessive sedation. Excessive sedation is one of the most common complications of antipsychotic treatment. The person becomes drowsy, sleeps for many hours, is hard to wake, moves slowly, speaks quietly and reluctantly. They may fall asleep during a conversation, meal, or watching television. Sedation itself is not dangerous, but it can completely disrupt daily functioning. The person loses their daily rhythm, has no energy for hygiene, eating, contact with others, and, above all, loses motivation. The caregiver should note such symptoms and discuss them with the doctor. Excessive sleepiness means that the body is overloaded by the dose, and often a slight reduction is enough to restore balance. Apathy and emotional blunting. Some medications, especially in too high a dose, can make the person emotionally empty, indifferent, and withdrawn. They stop reacting to things that used to move them, rarely smile, do not initiate contact. This is not depression, although it may look similar. It is a state caused by excessive blockade of dopamine receptors. The caregiver is often the first to notice that something has gone out in the person's eyes. This is an important sign because excessive emotional flatness reduces quality of life and often discourages people from continuing treatment. The psychiatrist should know about this. Sometimes a small dose adjustment allows liveliness and naturalness to return. Too rapid weight gain or sudden change in appetite. Sudden weight gain, appetite fluctuations, or compulsive eating are often the result of pharmacotherapy, but if they appear abruptly and intensely, they may indicate that the medication is poorly tolerated. The caregiver should observe the rate of weight gain, the types of foods the person particularly craves, any loss of control over eating. The metabolic changes described above do not always mean that the medication is wrong, but rapid or dramatic changes always require a discussion with the doctor. Worsening concentration and slowed thinking. The person may say they can't gather their thoughts, that their brain feels like it's in syrup, that everything is too thick. These are typical effects of medications which, in too high a dose, slow the processing of stimuli. There may also be difficulty performing simple tasks, long hesitation before actions, slow speech. If such symptoms do not subside after a few weeks of adaptation to the medication, there is a high likelihood that the dose is too strong or that the preparation is not suitable for this person. Worsening psychotic symptoms after a change of medication. Paradoxically, in some people psychotic symptoms may intensify after starting a new medication, more delusions, stronger voices, greater anxiety. This does not always mean that the medication doesn't work, sometimes it is a transient adaptation period. But if symptoms keep worsening over several days or weeks and there is no improvement, the caregiver should inform the psychiatrist. In practice, particular attention should be paid to sudden onset of aggression, dramatic mood swings, increased suspiciousness, hallucinations appearing in new forms. A medication that does not stabilize symptoms must be adjusted. Paradoxical activation instead of calming. Some antipsychotics, especially at the beginning of treatment, can cause excessive activation instead of calming. The person may become nervous, irritable, excited, more talkative and more active. Sometimes it is hard to distinguish this from akathisia, but the mechanism is different. The activation comes from overstimulated brain centers rather than the motor system. If this activation is increasing rather than decreasing, a rapid medical consultation is needed. How to recognize that the person is not taking their medication. Irregular taking of medication, especially stopping it on one's own, is one of the most common causes of relapse in schizophrenia. Discontinuation usually does not result from bad will, but from impaired judgment. In remission, the person may become convinced that treatment is no longer needed, and in a period of growing suspiciousness, that the medication is poison. Sometimes the reason is simple forgetfulness, sometimes the difficulty of accepting long-term treatment. This is why the caregiver, who sees the person every day, has the best chance of spotting early signs that treatment has been interrupted. The earliest signs are often very subtle. They may be small behavioral changes, shorter sleep, greater irritability, tension, restlessness, trouble concentrating or sudden sensitivity to stress. The person may become more suspicious, withdrawn or agitated, and their statements may become a bit more chaotic. The caregiver usually senses intuitively that something is different, even if it is hard to describe in words. Such early signals are extremely valuable because they appear long before a full relapse of psychotic symptoms. Physical changes associated with stopping medication can be even more obvious. Sleep is often the first to be disturbed. The person falls asleep more poorly, wakes up multiple times, and after a few days may hardly sleep at all. Movements become more nervous, the eyes more restless and energy unnaturally high or chaotic. There may be psychomotor tension, fast walking around the house, agitation, and sometimes, on the contrary, large frustration and mood swings. Some people feel they have come back to life because the medication no longer slows them down, but in reality this is the first stage of neurochemical destabilization. Recognizing treatment discontinuation also requires understanding that people often hide this fact, not out of rebellion, but because of fear, shame, or distorted beliefs. You may then notice that tablets disappear in suspicious ways, but the person's state does not match what would be expected from regular medication. The caregiver may find thrown away tablets in the bin, the toilet, pockets, or various corners of the house. The person may believe they are protecting themselves from danger or that they are finally taking matters into their own hands. This is not a rational decision, it is a symptom of the illness. A frequent warning sign is also what the person says about their medication. They may say that the drugs are harming them, that they are already healthy, that someone wants to knock them out, that the tablets are poison, or that they don't need anything given by the doctor. Even a single such remark should draw the caregiver's attention, because it shows that a narrative of resistance to pharmacotherapy is beginning to form in the person's mind. The latest, but surest, sign is the return of psychotic symptoms. Delusions, voices, overinterpretation of stimuli, a sense of persecution, sudden sense of mission, anxiety, insomnia, or agitation, all these indicate that the medication level in the blood has dropped below the therapeutic range. At that point, the caregiver should not ask, "Did you take your meds?" but immediately contact the psychiatrist, because attempts at logical discussion usually only escalate suspiciousness. Talking to the person about regular treatment should always be calm, gentle, and free of accusation. A person who feels attacked will withdraw and hide their behavior even more. Messages need to be short, soft, and based on care rather than control. "I can see you're sleeping worse. I'm worried about how you're feeling. Let's think together what to tell the doctor. We don't have to decide anything right now. It's just important to talk about it with a specialist." This builds a sense of safety instead of an atmosphere of surveillance. It is worth emphasizing that clinical studies clearly show around 80% of relapses in schizophrenia are directly related to irregular medication use. This means that in the vast majority of cases it is precisely the caregiver who, through attentive observation and quick action, can prevent a severe episode, hospitalization, and a long period of suffering. The caregiver's role is not to replace the doctor or to control the person in an oppressive way. Their role is to notice changes and respond wisely. Cooperation, not coercion, is the key to stable, safe treatment. Caregiver Observation Log. A caregiver observation log is one of the most powerful tools in the whole treatment of schizophrenia. It is more important than most caregivers realize. It allows the doctor to see what the patient does not remember, does not want to say, cannot name, or does not notice at all. Schizophrenia is an illness that distorts the person's experience and their ability to describe it. This is why the caregiver, as a witness of everyday life, can pass on to the psychiatrist what in practice decides whether treatment will succeed, a real picture of how the person is functioning. The journal is not a tool of control but of cooperation. Its purpose is to collect important signals which, from the ill person's point of view, often seem minor: shorter sleep, more intense look in the eyes, less interest in conversation, a sudden change in interests, a slight increase in irritability, new fears, poorer appetite, quicker movements, muscle tension, or trouble concentrating. Each of these may look trivial, but to a doctor it can be the first sign of too high a dose, too low a dose, or a developing relapse. The journal also has a protective function. Chronic fatigue, everyday chaos, the person's nighttime awakenings and unexpected crises can easily distort memory. Under stress, dates, the intensity of symptoms and the order of events become confused. The caregiver may feel that this has been going on for weeks when only 2 days have passed, or, on the contrary, that the problem started yesterday, although the first signals appeared a month ago. Written notes help organize emotions and provide an accurate picture of what is happening. The journal is also invaluable for the psychiatrist. The doctor does not see the person in their natural environment, only during a short appointment, filtered by the person's stress and their social mask. Many people with schizophrenia look relatively calm during a visit because they understand that it is a formal situation. They will not show the first signs of insomnia, anxiety, agitation, or functional decline. The caregiver's entries, recorded as things actually happen, strip away those appearances and allow the doctor to draw the right conclusions. The journal should cover several key areas: sleep, appetite, energy, mood, concentration, social behavior, psychotic symptoms, side effects of medication, reactions to stress, conflicts, and physical activity. There is no need to write long descriptions. Often one sentence a day is enough. Many people use a 1 to 5 scale, others use short keywords, others, colored symbols. The most important things are regularity and honesty of observation. Entries should record facts, not judgments. Woke up at 3 a.m. and walked around the house until morning instead of was incredibly annoying. Keeping a journal does not mean invading the person's privacy. You do not write down their secrets or personal reflections, but facts about their functioning, just as a doctor would record facts about a patient after a stroke or with diabetes. Schizophrenia is a chronic illness and its course is changeable. Thanks to the journal, it is easy to spot patterns, that symptoms worsen with the change of seasons or weather, that conflict with a close person immediately makes the person's state worse, that poor sleep almost always precedes a relapse, that an increased dose does not bring visible improvement until about 2 weeks later. Such knowledge is priceless and genuinely improves the quality of care. The journal is also an emotional support tool for the caregiver themselves. It helps organize thoughts, name problems, and see the person's progress in black and white. In moments of exhaustion, it is proof that improvement really does happen and that crises do not last forever. It also helps to understand that certain behaviors arise from the illness, not from bad will. Many caregivers say that the journal has given them more peace than some consultations, because instead of acting in chaos, they see a process. Finally, it is worth remembering one more thing: the caregiver observation log is an expression of care, not surveillance. The person does not have to read it or approve it. You do not need to show it to them if it would cause anxiety. It is a tool for cooperation with the psychiatrist, for assessing treatment effectiveness, for early detection of relapses, and for building a safe environment. Without it, psychiatry works in the dark. With it, the doctor can guide the person towards remission more calmly, quickly, and effectively. Cooperation with the psychiatrist. For a person with schizophrenia, the psychiatrist is what a cardiologist is for the heart or an endocrinologist is for insulin regulation. They are not a doctor for the psyche in a vague sense, but a specialist in the chemistry of the brain, in how neurotransmitters work, how receptors respond, and how the body changes under treatment. This is why cooperation between caregiver and psychiatrist is one of the most important elements of therapy. The quality of this dialogue determines whether treatment is stable, safe, and effective. The caregiver is, in effect, the doctor's eyes and ears between appointments. The psychiatrist sees the person briefly, under controlled conditions in the consulting room, where symptoms are often less visible. Many people with schizophrenia can create an impression of stability for those few minutes, because their disturbances of experience emerge mainly in everyday settings, in the kitchen, on a walk, at night, in contact with family. The doctor therefore relies not only on what the patient says, but especially on what the caregiver can observe and report. Without reliable information, the psychiatrist is working in the dark. The key is to pass on facts, not interpretations. Instead of saying he's acting strangely again, it is better to say, for 3 days he's been sleeping only 2 hours a night, he avoids eye contact, irritability has increased, there's been nervous pacing around the house, he started saying the neighbors are plotting something. Concrete, observable data, things the doctor can relate to the action or inaction of medication. It is precisely these details that determine dose changes, treatment adjustments, and sometimes the need for hospitalization. It is important to remember that information about functioning in basic areas is extremely valuable to the psychiatrist: sleep, appetite, hygiene, ability to talk, energy, concentration, conflicts, and emotional reactions. These allow the doctor to judge whether treatment is effective, whether side effects are appearing, whether the body is tolerating the medication well, whether the dose is sufficient, and whether relapse risk is increasing. What seems like a trivial detail to the caregiver may be a warning sign for the doctor. Honesty is also crucial. The caregiver must not be afraid to talk about problems, because hiding anything can lead to a wrong assessment of treatment. The psychiatrist does not judge either the person or the caregiver. Their task is to optimize therapy. If the person is not sleeping, eats only sweets, refuses to wash, throws away pills, or spends far too long online, the doctor needs to know in order to respond properly. The psychiatrist is a partner, not a judge. The caregiver should also bring their own notes from the journal to appointments, even short and occasional ones. In the flood of emotions and duties, it is easy to forget important events, yet it is the details that shape treatment decisions. A brief list of observations allows the visit to be efficient and to the point, and gives the doctor a complete picture of how the person has been functioning between checkups. If the person does not want the caregiver to be present during the appointment, psychiatrists will usually still agree to hear from the caregiver separately, before or after the visit. In many countries, this is standard practice, because the patient's safety is more important than formal consent to the presence of a third party. The caregiver should know they have the right to pass on their observations to the doctor, even if the person with schizophrenia does not yet understand that this is for their own good. Cooperation with the psychiatrist also means attending follow-up visits. Schizophrenia requires regular assessment of extrapyramidal symptoms, which patients often minimize or simply do not notice. Only a specialist can assess their severity and decide on medication changes. This is another reason why the caregiver should encourage the person to attend monthly or regular checkups, even when their state seems stable. The most serious relapses often begin with minor changes that only a doctor can interpret correctly. Most importantly, remember that psychiatrist and caregiver are on the same team. The doctor brings medical knowledge, the caregiver brings practical knowledge, the person with schizophrenia brings their inner experience. Only combining these three perspectives gives a full picture of the illness. Only then can treatment be truly effective and the risk of relapse as low as possible. Summary: pharmacotherapy is the foundation of stabilizing schizophrenia, but its effectiveness depends on cooperation between three parties: psychiatrist, person with schizophrenia, and caregiver. Medication works only when it is taken regularly, in properly adjusted doses and under continuous specialist supervision. When the caregiver understands how these drugs work and what side effects they may cause, they can spot worrying signs earlier and prevent serious relapses, sometimes even before the person themselves feels that something is wrong. By observing day-to-day life, the caregiver becomes the psychiatrist's most important source of information. Detailed notes on sleep, appetite, behavior, and emotional state allow the doctor to adjust treatment more precisely, without guesswork, risk, or delay. Reporting facts rather than judgments, and clear communication based on mutual trust make therapy more stable and give the person a better chance of long-term remission. Knowledge of the different forms of medication, tablets, liquids, depot injections, and awareness of the dangers of stopping them gives the caregiver a sense of agency and safety. The ability to recognize early signs of destabilization, such as insomnia, irritability, anxiety, or the return of suspiciousness, can literally prevent another episode. It is the caregiver's vigilance and cooperation that make treatment work in practice, not just in theory. Ultimately, the goal of pharmacotherapy is not just to silence symptoms, but to create a stable foundation on which the person can learn to function, build relationships, and cope with emotions. Without medication, therapy does not bring results. Without therapy, medication does not restore a meaningful life. A caregiver who understands this balance becomes the person's most important guide in the real world, someone who offers a chance not only for survival, but for a genuine improvement in quality of life.